Hello, everybody. Welcome to Hand in Focus. Today, we have a very special edition of Hand in Focus in combination with the European Journal of Hand Surgery with the theme of trapeziectomy versus implants for thumb arthritis. Good morning to our friends from US and good afternoon to our friends from Europe who are joining us today. So on the US side, we have a hand team, which will consist of myself, Jeff Yao, and Asif Ilyas. I normally run these webinars together with Carl Eblin, but he's not able to join us today, and we'll be talking about trapeziectomy.
Good morning, Harvey. Good morning to our friends in the US from Europe, and good afternoon to my colleagues in Europe. My name is Zaf Nakwi. I'm a hand surgeon from Manchester in England, and the team I have with me is Jane McKechen from Scotland, Frederick Verstracken from Belgium, and Danny Heron from Switzerland. Great.
So the first paper today will be presented by Dr. Asif Ilyas, who will be talking to us about his paper entitled Thumb Basal Joint Arthroplasty Outcomes and Metacarpal Subsidence, a prospective cohort analysis of trapeziectomy with suture button suspension plasty versus ligament reconstruction of tendon interposition. And from Europe, we have Dr. Heron, who will be joining us and discussing his paper, Short-Term Recovery After Implant versus Resection Arthroplasty in Trapezial Metacarpal Joint Osteoarthritis. Our US expert today is Jeff Yao, who's an expert in the field of trapeziectomy and a great friend, a professor and director of hand and upper extremity surgery, fellowship at the Robert A. Chase Hand and Upper Limb Center at Stanford University Medical Center.
And I'd like to introduce Frederick Verstracken, our European expert, very senior surgeon and expert in CMC arthroplasty from Antwerp in Belgium, and a long-standing servant for FESH also.
So for today's presentation, we're going to start with the author presentations, and Jane McKechen will be giving a brief commentary on both papers. And then subsequently, this will be followed by expert presentations and a discussion, and then subsequently an open Q&A session among the panel as well as the audience. So just some housekeeping points. Please mute your microphones. Please have your camera off while the speakers are presenting. Your cameras can be turned on for the Q&A session. Please make sure that your Zoom screen name is your first and last name. And also, please ask questions. We do want this session to be engaging and interactive, and we'll try our best to answer all questions posed by the audience in the chat function. So without further ado, I'd like to invite Dr. Ilyas to start us off with his paper. Asif, please.
I will, happy to do it. So let me share my screen. So it is a pleasure to be with everyone today. So I am from Philadelphia on the East Coast of the US. So it is approximately 9 a.m. here. So I appreciate the international panel and the opportunity to speak on a very fun topic in hand surgery. And this is a topic that when I speak to my colleagues and fellows, I can tell you that you'll get 1,000 opinions from 1,000 surgeons on how best to manage this common problem. So it's always an interesting discussion. The paper that we're going to be focusing on was published in Hand a few years ago. I'm going to give you my disclosures first, and I want to just comment on one thing. So these are my disclosures. I want to comment that I'm going to be talking about an implant from the company called Arthrex. It's relevant here, and I have no relationships with them, so I have no conflict of interest with Arthrex. So that's relevant to our discussion here. So as mentioned by Harvey, this is a paper we'll be presenting that was published 2 or 3 years ago in Hand, where we looked at a prospective cohort of 2 study groups. One set of patients who underwent treatment with an LRTI technique, and that breakdown consisted of approximately 53 patients who had an LRTI technique, either with an FCR APL, and then the second cohort were those patients who were treated with a tightrope suspension plasty. Both sets of cohorts, both sets of patients had a formal trapeziectomy performed. It was a cohort study with multiple study surgeons, approximately 6, and we were divided into 2 groups based upon our practice preferences. You'll notice that there's really no difference in age in the patient groups, and it was approximately 80-20 female to males, and all eaten stage 3 and 4 cases. In terms of the breakdown, again, as mentioned, there was approximately a half and half between the tightrope and the LRTI. I'll talk a little bit more about that. The LRTI was broken up again into 34 APLs and 19 FCRs, again, based on surgeon preference in the 2 cohorts. For those who aren't familiar with the tightrope, I'll just spend one slide talking about that. So the tightrope suspensionplasty is a technique where a formal trapeziectomy is performed. In this case, all were performed in an open manner through a Wagner incision. Once the trapeziectomy is performed, a guide wire is then placed across the thumb metacarpal base into the index metacarpal base. Through this, a loaded suture is then run. It's approximately I believe it's a number 2 fiber wire suture with a button attached to one end. Once you run it from the thumb metacarpal base, you make a separate incision on the dorsal side of the hand and retrieve the guide wire and then suture through the base of the second metacarpal dorsally. You have to retract the index extensor tendon. You have a direct visualization of the guide wire exiting the index metacarpal base. You then retrieve it, and then you run the suture through, and then you place the button on the far side over the index metacarpal. You tension it, and then you just tie it off. And what this does is allow for a suspensionplasty where the suture is running from the thumb metacarpal to the index metacarpal base. It's quite strong. You can put a lot of tension on it. There's always controversy as to how much tension one should put on it. There's different techniques been offered, such as placing the tightrope prior to trapeziectomy so you don't over tension, or placing it afterwards. Some will say place it from index to thumb. We can talk about that later. But in this case, from thumb metacarpal to index metacarpal. So this is a technique. The LRTI I won't review since most are familiar with those techniques for surgical intervention. Here are some of our results, and I'm going to focus on the things that are most relevant, starting with subsidence. So what we looked at was outcomes of various parameters at 2 weeks postoperatively, 3 months postoperatively, and 1 year postoperatively. These things include a subsidence, dash scores, VAS, grip and pinch, and complications. And I'm going to focus on the important findings here. Firstly, on subsidence, there was a statistically greater, or I should say statistically significant less subsidence in the tightrope group at 2 weeks and 3 months. But interestingly, at 1 year, there was no difference in subsidence between the 2 groups, be it a LRTI or the tightrope. Then in terms of dash, there was a statistically significant lower dash score for the tightrope versus the LRTI at 2 weeks, 3 months, and 1 year. And the differences are listed here. We can discuss later if these are meaningfully clinically different, but they were statistically different. Most interesting was at 1 year, the dash came back at 7 for the tightrope and 21 for the LRTI. Most interestingly, when we looked at all the other categories, such as pain based on a VAS, pinch strength, grip strength, reoperation complications, there was no difference between the 2 groups. There's often comments on concerns about the the index metacarpal fracturing with the tightrope. We had no cases of fracture, and again, no case of reoperation at 1 year follow-up. So our conclusion of our paper was that the tightrope versus LRTI resulted in short-term tightrope relative to the LRTI, resulted in short-term improved resistance to subsidence and longer-term improvement in dash scores, but otherwise no difference in pain, strength, or complications. I'll stop here. Happy to have a discussion on this and share my thoughts further on these 2 techniques. Thank you.
Great. Thank you so much, Asif. That was great. Next, I'd like to invite Dr. Heron to share with us his paper.
Thank you very much for giving me the opportunity to present our paper. We published it this year under the title of a short-term recovery after implant versus resection arthroplasty in trapeziometacarpal joint osteoarthritis, and it was published in the Journal of Hand Surgery, European edition. My disclosure is I have a contract with Kerry Medical for teaching activities. What's the background? Implant arthroplasty gained increased popularity in Europe through the promising short-term results and We also believe, and that's why we also started that the double mobility implant technology provides better results, especially in terms of the complication of dislocation. So the hypothesis of our paper was that implant arthroplasty provides improved functional possibilities, faster, better key pinch, faster recovery compared to traditional arthroplasties in terms of resection into position arthroplasties. The aim of the study was to compare the functional results and especially the time of recovery of this new generation of dual implant arthroplasty compared to this resection group. So about that. So what was the methodology? We were comparing two cohorts. Both cohorts had similar rehab protocols, similar surgeons group treating them. The resection arthroplasty had mainly two different techniques, either using the FCR tendon or the APL tendon. The outcome measures were the same. So the brief Michigan hand questionnaire was used at baseline, 3 months and 1 year. The return to work in days, the pain at rest and in activities on a visual analog scale, the key pinch in kilograms, and we also recorded the complications. The two groups consisted of 147 patients who received an implant arthroplasty in the period of 2018 and 21. We used the Touch double mobility implant, which is quite popular in Europe at the moment. The resection group consisted of 127 patients with a resection arthroplasty, just as I said, either with FCR or APL tendon in a period of 2014 and 2017. We used our own registry data from a prospective registry at our clinic. So since many years, we are collecting these data in this type of intervention, and they're all prospective. So we tried to compare the groups the way that we were selecting similar age groups, similar sex distribution, no significant difference in functional status pre-intervention. Of course, and that's a little bit the nature of the patients we selected for resection arthroplasty, we had more so-called stage 4 Eaton-Litter classification patient in the resection suspension interposition group. I think that's one thing we have to discuss a bit later. You see here the implant. It consists of 3 different parts. It's a cup, which is brought into the trapezium. There is a stem in the metacarpal brought in, and there is a connection in between with the part which has the mobile bearing polyethylene head, which provides then this kind of double mobility. These are the distribution of the 2 patient groups. As you can see, there was no significant difference in sex age distribution. There is, as I already mentioned, more patient in stage 4, Eaton stage 4, although I have to say, and we can discuss this a bit later, personally, I think stage 4, Eaton stage 4 is not just a progression of Eaton stage 3, but it's a different disease because it involves as well the CMC joint as the STT joint. There have been more patients being employed in the implant group just by selection. This is one significant difference as well. How about the complication in both groups? They were so-called, we distributed them among non-operative complication and operative complications, which needed a re-intervention. In the non-operative group, there were more Döckermann tendinitis. This is a fact we know already from former publication that the first extensor compartment might be at risk, maybe due to lengthening of the thumb if you're doing an implant arthroplasty. However, in the resection and suspension interposition arthroplasty group, we had more CRPS patient or CRPS looking patient and more patient with persistent pain. Difficult to say, but it seems that most of them were related with the superficial radial branches, which has been probably more exposed during the intervention of a resection arthroplasty than implant arthroplasty, which requires a little less space. The revisions were distributed on the implant side. We had one implant revision early in the case. So in retrospective, it was a technical error. The cup was not properly placed. We had one carpal tunnel to release and one trigger finger to release. We had 2 revisions in the resection arthroplasty group due to instability and subsidence, which was still, after 1 year, symptomatic. Also 1 carpal tunnel and 1 trigger finger. How about the functional results? This is quite a rich table. I just go through that. So what we can see that after 3 months, Brief Michigan, hand questionnaire, pain at rest, pain at activities in daily living, and key pinch were all significantly better in the implant group. However, after 1 year, the statistical difference was only on the side of the key pinch. All other measured factors, all other outcome factors were similar, implant arthroplasty versus the resection group. Return to work was significantly faster, half of time compared to the implant arthroplasty to the resection arthroplasty, pretty impressive. And for us also a sign of a functional recovery in that regard. So in the discussion with the focus on relevance, we can say that in the comparison of the 2 cohorts, which were quite similar in terms of patient characteristic, there is a significant faster functional recovery, as well as a return to work, which is well interlinked. There's a significant better key pinch, not only in the short term, but also after 1 year. There's no difference in the Brief Michigan and no difference in revision rates after 1 year. The limitations, of course, there is no prospective randomized study of both groups, so it's not have been done in the same time period, but in a very, as I already mentioned, very similar surgeon and therapy group. But there are a resection, suspension, interposition data group were prospectively collected, so we think quite comparable. The return to work is not a hard endpoint. We are aware of that, but it relies on different factors. But for us, it's kind of a sign of a functional recovery. And 1 year follow-up, of course, especially in the implant group, is too short to judge a revision rate and comparing to both groups. So what we could discuss, not only with that paper, but I would like to share it with my colleagues here about the value of the Brief Michigan hand questionnaire to detect really different and sensitive enough functional differences. Because the clinical results we observe in clinics since the introduction of implant arthroplasty are much more spectacular than the significance and the numbers we have calculated. The often heard comment from patient is one proof of that. I never had that in other hand surgical implant surgery, that they telling me, I have the impression I never had surgery on my thumb. It feels completely normal. So based on this clinical observation and these data and objective results, implant arthroplasty became our standard procedure in isolated CMC1 osteoarthritis. Thank you very much.
Great. Thank you so much for your great presentation. Next, I'd like to invite Jane from our European team to just give us some comments about both papers. Jane, please.
Well, thanks very much. Now, from an editor's perspective, there are 3 questions that we want to know the answer to when handling papers such as these. Is it new? Is it true? And does it matter? And if we start with, is it new? Well, the debate surrounding the optimal surgical treatment of base of thumb arthritis has been running for many, many years. The tightrope, however, is a more recent innovation. And although there are several previously published studies, they've all come in the last few years. So several researchers have asked the same question at around the same time. And of course, Daniel Heron has previously published the 2-year outcome of the touch prosthesis. But until last month's journal, there were no data comparing it to trapeziectomy. So both papers are asking a fairly topical question, which is not firmly answered in the literature. And then if we move on to, is it true? Well, this is where editors have a field day, because we look at the methods and decide from the methods how robust the data is and how it should be interpreted. Both studies are cohort studies. The study from Shanuga et al. Has data extracted from what appears to be a prospective database, and the methods and statistics are well described. In Shanuga's study, as an editor, I would like to see a further comparison between the patient cohorts. And this is why randomization always makes for a more powerful paper, but lack of randomization doesn't negate the impact of a study. Although it's not specifically mentioned, there is an increased number of left-handers in the tightrope group in Shanuga et al. Study, and it's not clear from the paper whether this is a significant difference, but I would want to know why. It may be that these patients are more manual workers than the other groups. However, otherwise, the results are clear and well illustrated, and the authors have chosen the Quick Dash for their outcome tool. That's very, very popular tool to use for upper limb papers, the most popular, in fact. It's very versatile and often used in prospective databases, because of its wide base of responsiveness to all upper limb conditions. But it may, however, lack specificity for thumb-based problems. And despite this, the authors have demonstrated that Q-dash is better at 1 year in the tightrope group, but pinch strength and subsidence and pain are all similar. Now, Heron's group has used historic cohort groups with some differing characteristics, including the Eaton stage and employment status, and presumably that reflects a slight change in their indications for surgery over the course of a 10-year period. The difference in employment status is important here because the paper concludes that patients with arthroplasty return to work earlier than those without. And as an editor, I would immediately want to know that these variables had been accounted for when statistically analysing the results. And in this case, the authors used a multivariable linear regression analysis in order to ensure that the appropriate conclusions could be drawn. So Heron's group had chosen the brief Michigan Hand Questionnaire as their problem of choice, largely based on their previous work and their involvement with the ICHOM core outcomes set. So that's one of the problems that editors face, is how to compare between studies when different outcomes are used. But their reasoning is very robust, and with an earlier return to work, key pinch strength was the only other difference at 1 year. So both papers have fairly robust methodology. And the last question we want to know the answer to is, does any of this matter? Well, it is important to understand recovery rates and understand return to work, but both studies have an endpoint of 1 year. And the obvious question when you're looking at papers that use implants, whether it's a tightrope or a prosthesis, is whether in the longer term these implants will start to fail, and that failure rate may negate any early advantage that you see. So in summary, both studies have added some understanding of the potential advantages of one technique over another, and they are both new, true, and possibly matter. But as an editor, I would encourage all potential authors listening to collect their own data and undertake more randomized controlled trials in this area. Thank you.
Great. Thank you very much for your insightful comments, Jane. It's good to know that we're certainly on the same wavelength at hand, as well as the European Journal of Hand Surgery, about how we evaluate the papers. I totally agree about the comment about the follow-up. Ideally, we would have 50 years follow-up on every single paper, but obviously that's not possible. But thank you very much for your comments. So next, I'd like to invite our expert from the US, Dr. Jeff Yao, to give us his take on trapeziectomy.
All right, thank you. Can you hear me okay?
Yes, we hear you great.
Great. Thank you, Harvey, and Thank you to all our colleagues on the call today. It's a real honor and pleasure for me to be part of this really impressive panel. So I'd like to share with you kind of my thoughts on thumb CMC arthritis. Before I get into that, though, I'd like to put a short plug in for the IFSSH meeting, which we will be hosting in the US in March of 2025. It's in a wonderful venue, and I invite you all to come participate. As one of the program chairs, we've been working very hard to put together a very impressive program for everyone who attends. This is my disclosure slide, and I think it is important to indicate that I do have a financial relationship with Arthrex, which is the company that does produce the Tightrope. My next disclosure is I love our European colleagues. In fact, this is just a few days ago in the operating room. This is the cap that I wore in the operating room. So I like to think of this more as a discussion than a true debate, mostly because, quite frankly, implants are not available in the United States. I'd love to use an implant for treating thumb CMC, I should say prosthesis for treating thumb CMC arthritis, but it's simply not available. So I'll be focusing on resection of the trapezium and what do we do after that. So there are multiple surgical treatments for thumb CMC arthritis. This is by no means an exhaustive list, but these are the most commonly performed, at least in the United States. And then for the purpose of this discussion and the hour-long journal club, we'll be focusing on really these four different techniques. So just historically, the trapeziectomy alone has been was popularized by Jervis and continues to be done worldwide, but particularly in the United States. It was repopularized by Roy Meals and his group. And this is a number of papers that he published in the 2000s. And this is one of his papers with an average 7.3-year follow-up, with the patients doing quite well. They did report an average subsidence, however, of 77%, but they also found no correlation of that subsidence with function and pain. The LRTI was born in the mid-80s. Burton Pellegrini published on it, and it's really been popularized ever since. It's got a long track record. It works very well. And the important thing is most of the surgeons operating today either trained in the era of Burton and Pellegrini and the LRTI, or trained or are trainees of someone who trained in that era. So that's why in the United States, at least, the LRTI continues to be probably the most frequently performed procedure. And for good reason. This is just one of many studies that have looked at the success of the LRTI with a follow-up of 9 years. This is Tomeno's paper in 1995, with, again, excellent outcomes measures with an average subsidence of only 13%. So it's a very successful procedure. In fact, our own Jennifer Wolf, our past president of the ASSH, published about a decade ago a survey study of U.S. hand surgeons and found that the vast majority of ASSH members prefer the LRTI for treating patients with Eaton 3 thumb CMC arthritis. And it's important to point out that this came out in 2012. And since then, there have been a number of different versions of the technique that have been described. And I am interested if this paper is repeated now, if the data would be somewhat different. It's also important to point out that in this paper, implants didn't even make the list. It was probably in the others group simply because it's so infrequently performed in the United States. And so there's a number of different implants that have been described. And unfortunately, in the United States, the results are still very preliminary. And again, we don't have nearly the robust literature or experience that our European colleagues have, unfortunately. It's also to point out that, as the saying goes, all roads lead to Rome. Patients treated with all techniques do well. We've just heard that from both of our papers. The primary objective, in my opinion, is to remove the bone-on-bone pain generator. And I think that all these techniques lead to a comparable relief of pain with comparable improvements in range of motion and print strength. But let me just briefly look back at some of the historical literature and the evidence. And probably the most powerful are the Cochrane database reviews, which look at multiple different studies, multiple different techniques, And of all these, at least in these 3 studies from 2005 and later, they found that all of them did similarly in terms of the outcomes measures, with less complications with trapeziectomy alone. This was continued in 2009 and then in 2015. But again, a lot of this predated some of the newer techniques that we're discussing today. But the point here is that simple removal of the trapezium seems to be all that needs to be done. Everything else seems to be, as we say, icing on the cake. In fact, Tim Davis's group looked at doing a trapeziectomy alone, trapeziectomy with an interposition, or a form of LRTI, and again found no differences in any of the techniques. So it's just simply removing the articular surface between the trapezium and the metacarpal can be just fine, and you can pin it open and let the hematoma form within the space. So as Dr. Elias pointed out, historically we use K-wires, but I do think the suture button construct is useful because it's implanted, it gives immediate stability and allows for immediate range of motion. So this is our journey of using this technique. We described it in 2010. We described it arthroscopically first, but then use it open as well. And you can see at time 0 with removal of the trapezium, there's complete subsidence of the thumb metacarpal. But again, at time 0, you put the implant in, and there's excellent resistance to subsidence with no loss of range of motion. This is a typical patient that we would see 5 days postoperatively after having the procedure done. And I do understand that with implant arthroplasty as well, you can have similar results, but compared to an LRTI or some other resection technique, routinely I would not get this type of range of motion just 5 days after surgery. And this is a patient basically done after about 6 weeks. We published on our midterm clinical experience, and we saw, again, the results are very similar to what's been published and discussed already today, with really minimal complications. And we're working on and submitted our minimum 10-year follow-up now. Again, outcome strengths are very good. Mean follow-up of 11.5 years, and their trapezial space height remains stable at about 70%. So we are finding that this is not only useful in the short term, but also has durable results. And again, I may be biased, but there's a lot of supporting literature to support this technique as well, including Dr. Elias's paper that we just discussed. So I won't go over his paper because he did a very nice job summarizing that. So in the interest of time, I'll just skip through these slides. I'd like to share our thoughts again why implants are not popular. The main issue is that the FDA has not approved the majority of these implants. I think a lot of these companies are finding that the costs are not worth pursuing, perhaps. That's just a theory of mine. I've asked a number of my trusted colleagues around the country to get their thoughts as to why this is not popular as well. I think we also have had a long history of failures with different implants, whether it be the Orthosphere, Artelon, Trapeze, all the different types of implants. For whatever reason, in the United States, we've had a history of failures. The cost can't be too underscored. There's definitely a cost difference between an implant versus the just resection arthroplasty. Potentially, our American patients are not as compliant as the European colleagues. So potentially that's where some of the failures came in. And again, I do think we have good, cheaper alternatives, whether trapeziectomy alone, just removing the bone, or the LRTI. Again, we have 3 generations of hand surgeons who have trained on it in the United States, so everybody feels comfortable with it and the results are good. And I do think that the suture button suspension is a good, cheaper alternative. So I think it's multifactorial why implants are not popular in the United States. So to conclude, for thumb CMC arthritis, in my mind, in 2023, I think obviously non-surgical management is useful for the initial management, and all surgical measures seem to lead to acceptable outcomes as long as you remove the bone-on-bone pain generator. I don't think the literature supports any ligament reconstruction or interposition. I don't think that implant is needed. I do think that suspension is probably needed. Is this suture button suspension needed? I don't think so, but in my hands, it leads to a faster rehab. We don't have to remove any K-wires in 4 weeks. We start range of motion at 3 to 5 days, and we don't need to wait for anything to heal. So thank you very much. Here's my email if you have any questions.
Thank you, Jeff. That was great. Thank you so much for sharing with us your experience and the valuable learning points.
Great, thank you, Jeff, again. And now I'd like to invite Frederick Verstraeken to give us its talk on arthroplasty.
Thank you, Zaf, and I'm really honored to be invited as an expert in this this webinar. But basically, I think every hand surgeon who's looking, it feels like an expert. This is a very common problem. All of us have a strong opinion about what we do and feel that we're doing the best for our patients. What I do is based on our own research, on literature, and on primarily on my clinical experience treating these patients. I've started using joint arthroplasty now 15 years ago, primarily because I had a colleague in town who was doing it for many years, and I saw his excellent outcome, both short and long term. I slowly started. I was as critical as everybody who has not used it, but it very quickly became my preferred treatment option. I have a conflict of interest that I'm involved in the training of surgeons for Carrier Medical, one of the producers of this prosthesis. Now, the arthroplasty that we are currently using is very similar to ones that were brought on the market already in the 1990s. So we have long-term data. It's a cementless coated implant, ball and socket, metal on polyethylene. And the only thing that's really changed in the last 5-6 years is that we now have a bipolar polyethylene insert, and that's maybe one of the reasons why it's really catching up in Europe now, because it significantly decreased the risk of instability, but I'll come back to that later. Now, looking at the study presented by Daniel Herron, and I will not repeat it, it was presented excellently, but this study confirms around 8 papers that have been published already comparing joint arthroplasty with resection arthroplasty, and they all come to similar conclusions. The joint arthroplasty patients recover significantly faster. They have somewhat better function when you look at pinch strength. But if we look at patient-rated outcome scoring, that's very similar. What's impressive in this study, and I'll come back to that, is that the complication rate was very similar in the 2 groups, and at the end, that patients and surgeons prefer the implant. As you know, this study comes from the group of Zurich. They have done extensive research on the topic of CMC osteoarthritis. They've published on different topics such as cost utility, indications, outcome measurements, results of resection arthroplasty, and now recently on the results of total joint replacement. And the fact that these group who sure have been very critical about joint arthroplasty have changed their practice and now made joint arthroplasty their first treatment option is significant, I think. There is a learning curve, and this group looked at long-term results and showed that when they excluded the first 30 cases, there was a significant improvement of long-term survival. And that's impressive because in the study that Daniel presented, probably these surgeries were done by 8 surgeons, probably included their learning curve, and still they had a very low complication rate. Why do we see complications? Because it is a technically demanding procedure, and especially the early complications such as fractures, bony impingement, distraction, instability are very often surgeon related. So it's a technically demanding, and you need, if you want to start doing this, you need to train well before embarking on it, or you will have a high complication rate. And just to show one picture, sometimes the room for error is very little, and it's primarily the insertion of the trapezial implant, the cup, that is the most critical step in the procedure. Now, the good thing that we have now, and compared to the earlier prostheses that were brought on the market in the 90s, is that we now have bipolar polyethylene inserts. And if instability was one of the major complications early on, with even very experienced surgeons at about 3 to 5% instability, that problem has almost totally disappeared. And there is a paper, and I think it was a question on this in the chat box already, but there is a paper published that compared from the same group of surgeons comparing their single with their dual mobility results, and the dislocation rate decreased from 7% to 0.5%, so almost zero. And probably this is what convinced many surgeons now in Europe to start using this prosthesis. Why is the better grip strength? And that's one of the conclusions of the study that was presented. Because with the joint arthroplasty, we can restore alignment, length, and balance of the thumb much better than with resection arthroplasty. I'll show you one case. This is a 62-year-old hairdresser, very unhappy because he wasn't able to do his work because of pain and loss of strength. This is his X-ray, quite dramatic disease. These are not the easiest cases, but with careful planning and meticulous surgery, you can restore this very weak and painful thumb into a almost normal functioning thumb, well aligned. And this is range of motion after 2 weeks. And there's a study published, specifically looking at MCP hyperextension correction, which confirmed that with the prosthesis, this was almost always the case if it wasn't beyond 30 degrees. Now, do we have long-term data? Yes, we have them on the unipolar prosthesis. There's about 3 studies that have been published that have over 10 years of follow-up, and I'll just look at one of them. The survival rates, even long-term, are excellent, with 92% survival at 10 years and a very low signs of loosening. And also the clinical data at 10 years were well maintained with a low VAS score for pain and excellent function. And this is very similar to the outcome that is published for hip replacements in the Swedish hip register, one of the best registers for joint replacement in the world. And I know a case series is not a register, but it at least shows that we're getting close to those hip results. And then in conclusion, there's pros and cons for everything, and it really depends on your local situation, on your experience, and the healthcare system in your country. But in my opinion, implants are at least a valid alternative to trapeziectomy. And I have not come across a surgeon who has tried it, who has gone through the learning curve, and who has not adapted it in its practice. I'm looking forward to an interesting discussion on this. Thank you very much.
Great. Thank you so much. So first of all, I'd like to thank all our panelists for excellent presentations. I certainly learned a lot, and it's so great to hear the contrasting viewpoints between Europe and the US. So there was a question in the chat about how the passive range of motion has changed from old implants to a newer implant. So in the US, we do not have dual mobility implants. So I'd like to start off by asking our experts in Europe to just talk a little bit about how the implants have changed over time and how they have improved and how this has influenced your decision to use this in practice. So maybe we'll start off with Frederick. Could you give us your insights about how implants have evolved over time and gotten better?
Question. So I started using unipolar implant about 15 years ago. I was happy with it, but I had a dislocation rate of about 2-3%, which was one of the real problems. Then we got the dual mobility implants that came on the market about 5-6 years ago, and the dislocation rate came back to almost zero. We were a little bit worried in the beginning if the polyethylene was going to do as well with the bipolars one. But then if you look at the hip literature, just several studies looked at bipolar implants for hip arthroplasty, and there they have not shown any increased polyethylene wear compared to the unipolar ones. What we've not seen is increased range of motion or things like that. I think with any procedure, specifically with arthroplasty, the range of motion correlates with the preoperative range of motion and much more than with the kind of implants that you use, I think.
Thank you. Any comments from Daniel or Jane or Zaf?
If I may, I think we have to distinguish between the different implants, and it has been pointed out by Jeffrey. You know, implant is not implant, and the concept of different implants is somehow completely different than what we do now today in terms of that we are replacing the joint. So the implants we have experienced in was the pyrocarbon, because we were always on the search for an implant solution, especially in younger, more active patients. Doing all these studies, which has been quoted, thank you very much, Frederick, we realize more and more that there are functional deficits, although, and that's true, the patients are extremely happy after resection arthroplasty. Why are they happy? They got adapted to their functional deficits, and they are happy because there is no more pain. But if you ask a patient after resection arthroplasty to pick a small object from a table, it's virtually impossible. They don't complain about that. You have to ask them. So that's the reason we were looking for implant arthroplasty solutions, because we realized that if you provide a stable system, as it has been shown by Frederick, quite impressive, the functional possibilities of the thumb are much better. We were waiting until we were sure, or we had the evidence, the better evidence that the results are long lasting, and the dual mobility publications also being not only from the French-speaking part of Europe, but also coming from the Scandinavian countries, persuaded us to start with it. And again, I just confirm what Frederick says: once you started, you're an addict.
Okay, thank you. Thanks, Daniel. I'm going to ask a question now to the US panel. Jeff, Asif, and Harvey. So you mentioned that, Jeff, I think a paper that shows there's no correlation between thumb metacarpal subsidence and outcomes or pain. But of course, the presentation by and the research by Asif and the work you've done yourself on the tightrope would indicate that this is a challenge, or this is an issue that we face as surgeons doing trapeziectomy, is the thumb metacarpal subsidence. I imagine that's the indication for doing it. And based on the work that has been published, would you, I know it's difficult, I mean, everyone is, not all the experts and authors have given their disclosures today, but do you think it's a valid option to use a tightrope rather than just doing FCR sling or just trapeziectomy alone?
Yeah, great question, Zaf. I do think that if you look at Dr. Miel's cohort of patients, they're generally more on the elderly side, to put it lightly. So the demands are probably less than some of the younger patients that we've been discussing so far today. And so as such, as Dr. Herm said, patients, as long as their pain is removed, they're generally happy. But 77% subsidence, I do worry about the functional ability of that thumb. And so although their pain is resolved, I do think, as he pointed out, their functional limitations maybe they may adapt to, and they may still be satisfied despite the fact that their function is limited. So I do think that subsidence is something that we try to prevent, and that's why a number of different options have been described, whether it be the tightrope or suture suspension or using a tendon or any other method to try to maintain the length of the thumb. I think is important to try to maintain strength, power, and pinch. And that's why we use this, and that's a common cause of a failure of whatever technique that you use after resection arthroplasty. If there's subsidence, or one of the most common causes of a failure, whether it be persistent pain or loss of power or strength, it's usually subsidence, which is the primary issue. So that's what we're trying to prevent with all of these types of suspension plasties.
Thank you. And Asif, coming to you, obviously the paper is about primary trapeziectomy and the use of the tightrope. In the UK, I've seen a number of colleagues who've attempted to use the tightrope following thumb subsidence, but the evidence published does not seem to suggest that that particularly adds much, and there is an equal complication or revision rate. What is your perspective on that, and what do you do personally when you have a failure, a thumb subsidence? I mean, where should we go with that?
So thanks for the question. I'll answer your question. I have a couple of comments as well. So that's a great question, and what I often tell my trainees: subsidence doesn't matter till it matters. And we've all seen enough of these patients who've had LRTIs, who've had plenty of subsidence and have no symptoms from it. They'll come in for different things. You'll get imaging. You'll be like, wow, that thumb metacarpal is sitting on the scaphoid, and the patient's asymptomatic. So it doesn't matter till it matters. And the paper that Jeff referenced is one that we often reference. It shows it doesn't typically make a difference. Yet we are careful with it, right? And we look at those because we know it could be a proxy for failure potentially. To answer your question, when I was first exposed and started utilizing tightrope was for failed CMC arthroplasty performed with an LRTI. That was my first indication for it. And I'll give you just a 2-second story. I had a patient who I had done bilateral LRTIs, one side failed. She had symptomatic subsidence. I did the tightrope and she asked, why didn't we just do this the first time? And I thought it was interesting. So I started to think about this. And so it was initially used for me for failed LRTIs, and now later became a primary tool. So I don't think it matters till it matters, but we want to be mindful of that because it can become a problem. I just want to comment on a couple things if I may, and I'm going to be a little bit more provocative here, if that's okay, for the sake of the journal club. So I think all the studies show that in the short term, anytime you put in implants that tension the area and provide more stability, tightrope implants, patients tend to do better. Our studies showed that. My colleagues overseas papers show that. But really, to talk about any implant with 1-year data, frankly, is irrelevant, because we know that over time is really what the question is, right? And I'm not against using implant arthroplasty. I use implants for lots of different other things as well. But we always look at the longevity of those implants. And at 1 year, it really shouldn't be anything that we should base our decision making on, my study included. And I will tell you what I tell my trainees with the tightrope. The tightrope's advantage for me is simply short-term advantage. It feels more stable to patients sooner. I don't have to put any pins in and I can move them quicker. That's it. And ultimately, the paper that we did showed that really long-term doesn't make a huge difference. Yes, there's a dash difference of 7 versus 20. We can comment on how good the dash is to really assess outcomes. But that aside, there's really no advantage. The advantage for me, tightrope, was simply better early. If I'm using an implant, I really have to know not how they do at 6 months, 1 year. I really have to know how they're going to do 5, 10, 20 years later. And that's the challenge for all arthroplasty literature, not just thumb arthroplasty. So we really need to know that to know if it's valuable or not, because short term is not going to make a whole lot of difference. And second thing is cost. We're living in a cost conscious environment. Even with the tightrope, which isn't super expensive, there's pushback at many centers to even use a tightrope. So the question is, if you're going from a tightrope to an implant, what are some of those cost considerations that need to be made? So I just want to put that out there for discussion.
Thank you, Asif. And I guess before I hand over to answer the implant question to Daniel and Frederick, just to, if I could draw you into the discussion about what you do with a failed symptomatic subsidence of metacarpal, because my experience with the tightrope has not been successful. What are you and what are Jeff, maybe Harvey, what are you doing with those? What's your go-to operation for that situation right now?
So I'll just comment very quickly first. So if it is a procedure done in a different manner, most likely an LRTI, I do revise with a tightrope, and then I'll interpose as well. So there's something in that space. Does it make a difference or not? It's hard to know. Many of us have been in a case that's had a prior LRTI, and that space that we often feel will be filled with scar tissue or tendons is empty. And it's a bizarre phenomenon, which challenges our understanding of what an interposition does really, what in reality. In the setting of a failed tightrope with subsidence, and I've had 2 or 3 of those as well, longer term, because I think it is a suture and it could fail, it could fatigue over time. Then I can still revise, or I can convert to an LRTI at that point, because those tendons, APL, FCR, are still in the field. They haven't been taken. So the opportunity to still do a traditional LRTI remains in that situation.
Okay, thank you, Jeff.
Yeah, as I've pointed out, I think everybody's, not everyone's, but a common entry into using these tightrope is for the failed, whatever, insert your favorite procedure. Someone loves to do an LRTI, it fails, what do they do now? And that's how a lot of people get their first experience with the tightrope. And so that's what I will do. As I've pointed out, a lot of times people come to see me because they failed their other primary procedure, and that's my go-to procedure. And I've also had my own failures of the tightrope, and I will not hesitate to go back and do another one if it failed because of subsidence. I also want to rule out other causes of failure, right? Failure can be due to a number of reasons. Is it underappreciated MCP hyperextension? Is it concomitant scaphotrapezoid arthritis that was misunderstood? Is it impingement of the thumb metacarpal to the second metacarpal? Those are 3 other possible causes of a failure of a thumb CMC arthroplasty. And so I want to make sure those are ruled out. And if it's truly the subsidence, then I will absolutely go back and do another tightrope. I feel strongly it is effective in the revision setting.
No, nobody's fusing first to second then? No, you're not doing that.
I will do that as a salvage only at the last possible thing if they failed multiple procedures.
I'm going to put the question that you both posed to Daniel and Frederick, which is, Danny, Frederick, we don't need 1-year outcomes, we need 20-year outcomes. So, and as you're answering that, could I encourage the experts also? There's a huge amount of discussion going on in the commentary, in the meeting chat, and maybe some of you can answer some of those questions, because this is such an interesting topic, and I'm sure we're not going to be able to answer all the questions. So Danny and Frederick, whoever wants to go first, we need to see your long-term data.
Of course, it's there's a full picture, and I only partially agree about the comments of not having short-term results, because recovery, going back to work, this is a big issue also economical wise. Since the introduction of implant arthroplasty in our department, we could save 1 position in hand therapy, because people didn't need hand therapy anymore. And the amount of patients being treated for CMC arthroplasty is so significant that they didn't have anything to do. So I think, there are different things you are looking at different times of a patient journey. And I think the argument by because not only for the functional results I've seen from my friends, but one of the arguments to start with implant arthroplasty was the revision possibility to go back to the traditional resection into position arthroplasty. And meanwhile, we have a publication showing that a secondary resection arthroplasty after implant arthroplasty produced a similar results. So this makes me really sleep well, also in terms of long-term results. Frederick?
Yeah, I fully agree, Daniel. And we have long-term results on the type of prosthesis that we're using right now, the non-cemented hydroxyapatite coated metal on polyethylene. We have at least 3 10-year follow-up studies with excellent outcome. And I work in a country, in an area where these prostheses have been very popular for more than 30 years already. And there was a colleague in town who retired, and I thought, now I'm going to see all this revision and all these loosenings of the prosthesis. I didn't see any. And that's also my impression. I've been doing it for 15 years now. I was expecting to see loosening and things like that coming up. Now I don't see them. And I think that's the experience from everybody that I know who's been using these prostheses for a longer period.
So those are really great questions, Zaf. And I just like to add that I totally agree with what Asif and Jeff said. I found the tightrope to be useful for revision cases with symptomatic subsidence. And I think you definitely need some form of suspension plasty. It really doesn't matter what you use. It can be a tightrope, can be some RRTI, can be anything. But I do think that helps prevent long-term complications. But, we're having this really interesting discussion about implants. And I think, the European panel is really convincing me that I should be using implants for all my cases. So I'd like to ask you guys, I actually have a double-barreled question. When would you not use implants? And what do you do for revision cases when an implant has failed? And what's your experience with that? Frederick?
We don't use it when the trapezium is not of sufficient height or of sufficient bone quality to take a non-cemented. But basically one of the only cases where we would not do it, and that sometimes we know that in advance, and then we will check on CT scan and see, or otherwise we find it out during the procedure, and then we can easily transfer to a trapeziectomy during the procedure, and we'll consent patients for both procedures. So the trapezial is the critical step in the procedure. The problems occur mostly at the trapezium, and that's something you have to watch out for. And the second question was revision. If I have a problem with an arthroplasty, I most often will turn it into a trapeziectomy. And as Daniel Herden said, the results of trapeziectomy with LRTI following a prosthesis are at least equal to the ones when you do it primarily.
We are a little less courageous. So our not contraindication, but relative contraindication is symptomatic STT joint arthritis. So our track record is not as long as Frederick's one, because I'm aware of having discussions with my colleague from Belgium and France with more experience. They tell us that a lot of symptomatic STT joint osteoarthritis are going away with the replacement of the CMC1 joint, which is interesting, but we are not that far. So at the moment, if patient has clinically, and this is easy to distinguish, STT joint arthritis, which hurts, we are more cautious and go to resection arthroplasty.
So
Well,
what I'm sorry, go ahead, Zah. Yeah.
I was going to say there is a question just for all the panel regarding MCPJ hyperextension indications for fusion. So I think it would be really useful for the audience to know what the various indications are from the panel regarding MCPJ hyperextension with whatever procedure they do, whether it be implant or LRTI or tightrope.
That was going to be my question as well. So it's great that we're on the same page. So anybody who likes to start off.
We'll go back to the USA.
Okay.
Let's go to Jeff. He's the furthest out.
I'm still waking up. No, it's no, thanks for bringing up that question, because I do think it's a very important thing to discuss. You know, obviously, if there's any arthritis, evidence of arthritis of the MP joint, I go to fusion. I do think that the MP joint should not be overlooked. I've seen many a patient with very minor MP hyperextension go on to have a very unsatisfactory result as a result after their thumb CMC arthroplasty procedure. So I think it needs to be addressed. I don't think it corrects after just treating the CMC arthroplasty as has been theorized in the past. So if there is dynamic instability, and I test the patient preoperatively, if it's dynamic instability, I favor a tendon transfer. I transfer my extensor pollicis brevis to the abductor pollicis longus tendon, so that weakens the pull of the EPB on the MP joint, but actually acts as a thumb abductor instead. If there's static classic hyperextension, then I do a capsulodesis. If there's both, I'll do both. And then and I'll do that up to about 50 degrees of hyperextension. After 50 degrees, then I do think that there's a limitation to how much you can get from a soft tissue procedure. And I'll do a fusion even if there's no arthritis at the MP joint. That's my algorithm.
Yeah, mine's not too different than what Jeff said. It is challenging to know how much to do when. I think it's easy when it's frank instability, arthritic, hyperextended, you know, more than 45, 60 degrees, the classic Z deformity. But that in-between area can be challenging and how aggressive to be. Whenever possible, my goal is to do a capsulodesis. I think it's easier technically, time-wise, and for the patient to recover from. But I'm never opposed to doing arthrodesis. I'm also okay going on a stage basis. So if the MP issue becomes a problem later, I don't think you've burned any bridges if you've done a capsulodesis or nothing to go to a fusion later. If that becomes a problem, and I've definitely have come across it a few times where someone had some MP instability, we didn't treat it or undertreated with the capsulodesis, it became more prominent post arthroplasty, and then you can convert that to MP joint to an arthrodesis later and some flexion. So I don't think you burn any bridges, but the question always is how aggressive to be early, and that can be challenging outside of the classic Z deformity.
I've never been a fan of having degrees as an indicator. I think you have to look at the thumb as a whole. And I was also had bad experience with all these soft tissue procedures. Either, you know, you limit the inflection and the hyperextension is coming back after 2 years. So either I do nothing or I do a fusion. And I talk to the patient. I tell him, listen, if you don't mind that your thumb is still looking like that, but it doesn't hurt anymore, we leave it like that, and we can do the MP joint fusion, which is, I think, a minor surgery also later. So over the years, I have been become more cautious to do all at the same time, but rather to doing staged, and then probably more than 50 or even 75% of the patient never will get a MC joint fusion after resection arthroplasty.
Frederick?
Yeah,
In
we
the,
do.
sorry, and in the implant arthroplasty, it's really impressive how you get that stabilizing effect. It's amazing. You would never think. You would never think. So I would never recommend to do a MCP joint fusion at the same time as an implant arthroplasty. Wait, if it's really needed, you can do it secondarily.
Yeah, fully agree with that. Usually around 25 to 30 degrees of hyperextension will correct by doing an arthroplasty and restoring length. We'll check it on the table, and if it's not corrected, then I'll do a volar capsulodesis with a suture anchor. I will only do arthrodesis when there is no passive flexion anymore. Sometimes these cases have chronic hyperextension and they will not go into passive flexion anymore, and those are the cases I'll do an arthrodesis. But most of the cases will be able to keep the MCP mobile.
I don't think we're too far apart on our management of the MP joints, it sounds like. My question to my European colleagues who use the implant, does the presence of the prosthesis or the stem in the metacarpal modify your choice of arthrodesis technique, i.e. if you would do a plate with the prosthesis or the stem obstruct your screw placement if you're using a plate fixation, how would you approach a fusion in that setting if you did it, or either primary or secondarily?
I do my arthrodesis with 2 crossed screws, and that's perfectly possible with the stem in place.
Same for me. And I've, to be honest, I was just recalling if I had a case which I had to do it in implant arthroplasty, because we are only 5 years out now doing implant arthroplasty, so it's a rare indication. But I think even with a plate, there is still enough space to fix it. But the cross screw technique with 2 headless screws is fair enough. It's a big fusion mass, and it heals pretty reliant.
If I may ask one more follow-up question, if the moderators don't mind, because as Jeff mentioned, we don't use the implant here, but do you find that with the implant, so first 2 questions with the implant. I assume there's some modularity to it, so that when you put the stem and the cup in, the neck component you can change to increase your tension across the CMC joint, correct? And do you find that secondarily corrects any pre-MP instability, or at least to some extent? How do you think about that in terms of tensioning it and then how it plays relative to the MP joint?
Yeah, absolutely. I mean, it's that ability that you have with the prosthesis that corrects the MCP hyperextension for sure. But both the lengthening and also making the base of the first metacarpal more stable attached to the trapezium again. So the adduction contracture is also corrected. Yes,
and you push it back in line, because 80% of these patients have a subluxation to the dorsal-radial side. So you put it back to and centralize it again. And but be careful, you know, with over-tensioning at the CMC joint, you don't help the patient. So you shouldn't over-tension that at all. So just having a supple joint which has a good joint play is still enough to do the correction of the MCP joint, and does a much better job than in the CMC joint.
Thank you.
If I may also ask a question, you know, you're making a very strong argument for the use of implants, and to Daniel and Frederick, do you have any insight as to why these implants are so well accepted in Europe and they haven't tried to enter the US market? To my knowledge, Carry Medical is entering the market for other things, but not necessarily a CMC implant.
First of all, Jeffrey, they're not that popular in Europe. You see two surgeons who are now very enthusiastic about this, but it's been very popular in some areas of Europe, and the popularity is dramatically increasing over the last 2-3 years. But it's still, I'm sure that trapeziectomy is still the preferred treatment option in most parts of Europe. That's one. And two, I heard that getting a total joint replacement approved by the FDA is a very complex process, and that's one of what stops many of the companies, I think.
I wanted to ask them a similarly based question to all the experts, with one eye on the time now. We've got over 100 delegates who are attending this webinar. Am I right in the take-home message that people are getting here is that if in the US our experts are recommending a trapeziectomy with tightrope, and of course for Europe they are recommending an implant as the default setting? Because worldwide, a trapeziectomy is still, of course, the primary procedure without any implant. So, Jeff and Asif, is that your go-to? Is you?
No, I wouldn't, and Jeff can correct me or share his thoughts, obviously. I wouldn't characterize it as that. I would say the trapeziectomy is the primary gold standard in thumb arthritis surgery. The corollary or the secondary aspect is, what do you do to stabilize the thumb ray following trapeziectomy? Do you do nothing, hematoma, pinning, tightrope, suture suspension plasty, etc.? I think where the consensus is trapeziectomy is necessary. Where there's lack of consensus is where the suspension plasty is. And I'm going to give you full disclosure here because I don't want to be inaccurate. I very much like the tightrope. I've used it for many, many years. But I too have been shifting to suture suspension plasty in the past year to two, because the data coming out on that is strong. It is an easier surgery. There's less implant costs. I don't need to use fluoroscopy. So there's some inherent benefits. So as surgeons, we always go to things that are easier and better and cheaper generally, or at least we try to, right? And so I'm moving that direction cautiously, but always with a critical eye. But I have a very short trigger to use the tightrope because I think it's a very effective technique, but I don't think it's the gold standard. I just think trapeziectomy is the gold standard.
Yeah, I agree with that as well, Zaf. I think from my talk, I think the primary thing is to remove the bone-on-bone pain generator. As Asif pointed out, what you do after that, it diverges into probably 15 or 20 different directions, and that's surgeon preference, it's surgeon training. As I pointed out, a lot of surgeons in the United States trained in the era of the LRTI, so it's still the most commonly performed procedure. I'm not here to say that the tightrope is the gold standard by any means. In my hands, I do it basically 99% of the time because it works for me and it works well. But I totally accept and understand that there are other techniques out there that provide a similarly outstanding result, and the patients are very satisfied with all those techniques.
So Zaf, I'd like to add to that. I think really the published evidence shows that the outcomes with trapeziectomy and anything else are equivalent. That's in the published evidence. But most surgeons in the US will do some form of suspension. Doesn't matter whether it's a tightrope or RTI or some other form of suspension plasty. And I think that's probably the general consensus and the gold standard that should be taken away.
We published on that. It's just I'm a little bit frustrated that nobody's quoting our paper, but we put a lot of work in that. We did an intraoperative measurement of the contribution of suspension versus interposition. With an external fixator and blah blah blah. So it took us 3 years to fabricate this device to measure that. So the conclusion is, there's a big difference between patients. So I think we are talking always about patients with osteoarthritis, but some of them, as we all know, we take the trapezium out, metacarpal one basis falls immediately to the scaphoid. And on the other hand, we have patients, we take the trapezium out, especially the peritrapezial patients, and the metacarpal one basis virtually doesn't move. So I think we are comparing apple to pears. So those one who are really unstable after trapeziectomy, in my limited experience, need some sort of suspension or interposition. And our measurement in this in vitro study has shown that the suspension is by far more effective than the interposition. So I think this matches a little bit that. Just one question, if I allow, Zaf, about the tightrope, because I was struggling with the tightrope as well, and I left it. And I think there's a very thin track to over tighten it or under tighten it. And I didn't find, because I've seen patients operated in St. Elsewhere Hospital, they came along after trapeziectomy with these thumbs. I don't know if you have the same experience. So somebody was really pulling on that tightrope as mad as possible in order to provide as much stability as possible. And this is devastating. These patients have a useless thumb. And on the other hand, if you don't pull enough, there is no use to implant this not really cheap device. So
I'm happy to comment on that. Like you mentioned earlier, with any implant, the positioning of the structures, positioning of the actual material is always critical, right? So no different with the tightrope. Obviously, it's not a prosthesis; it's an implant, but still, you know what I'm saying. So there's a couple takeaways. And there's some controversy here, but generally you want to be low with your guide wire and tightrope. So across the metacarpal base, across the thumb metacarpal base, and then across the index metacarpal base. If you go higher up into the shaft or higher up of either shaft, it tends to have a more adducted kind of stress on it. But if you're at the base, it has a more of an abducted and opposed position on it. So I think that's one of the mistakes. And I would also agree, training a lot of people, that I do find that there's a significant learning curve with putting in the tightrope guide wire. Jeff and I have done it for a long time and at a high rate. So we're very comfortable with that, with placing the guide wire. But there is a learning curve. And I would say it took me 5 to 10 cases at least before I felt comfortable how to drive the wire across the thumb base and the index base before I got comfortable with the orientation. And it can be difficult to get that just right in the beginning.
Yeah, a couple other comments. I absolutely agree. The over tightening is the #1 most common mistake that I see, and I get calls about this and emails about this all the time. You have to retrain your brain. I tell my trainees that, ever since you're a medical student, when you tie a knot, you tie it as tight as you can to try to get that knot security. That you don't want to do that in this scenario, because you will lead to adduction of the thumb and painful thumb to index metacarpal base impingement. So I absolutely agree. I would just say to Dr. Ilias's point, we actually did a study looking at the trajectory of the implant, and there's been another study that was published. I forgot who the authors were on that one more recently, which showed that the trajectory didn't much matter. So I respectfully don't think that the trajectory matters as much as the tightening. And so sometimes with my trainees, I'll put a clamp underneath the button, let them tie as much as they want to, because that clamp will provide at least 2 to 3 millimeters of slack immediately. And so to prevent that as a little trick. But I do think that this is #1 technical pearl. The other thing is, in terms of firing the wire, I like to use a C-clamp targeting guide. I know it's not popular, but a lot of people like to freehand it. That's totally fine. I use a C-clamp targeting guide. So I put it right on the ulnar aspect of the second metacarpal. So then when I fire my wire, I know it's going to go there almost every single time. So that makes it a lot easier, less futzy, less frustrating for people who are trying to hit the second metacarpal.
So we're actually about 18 minutes over. It's a Saturday with more than still 100 participants, which is pretty amazing. I have so many questions I want to ask, but it's probably about time we wrapped up. So I'd like to mention that CME can now be claimed for hand and focus. And for those of you on this webinar, you should get an email at some point, and CME credits can be claimed once every 6 months for all AHS webinars. Please apply for AHS membership. I do have a plug for the upcoming AHS meeting in the Bahamas. It's going to be a great resort, and I've actually been there myself. It's actually in the nicer resort that's newer compared to the Atlantis. The water park is fantastic, and it's going to be a great experience, for yourself and your family. So please join us if you're able to.
Thank you, Harvey. First of all, on behalf of us on this side of the pond, thank you for this collaboration. I think it was an excellent webinar with some great debate and discussion. I am looking forward to Washington. Jeffrey has been in touch, and the Bahamas also looks amazing. I would appeal to our US colleagues to come and visit us in Europe. FESH has a very dynamic and diverse program every year. This year in 2024, we will be in Rotterdam. We have between 2,000 and 2,500 delegates, usually from about 80 countries, although there are 29 countries that make up the FESH. We usually have about 60 surgeons coming from the US. Hopefully we can have double that number in Rotterdam, so please do come. And it's been lovely on this meeting with you, Harvey, and all of our colleagues.
Yeah, likewise, it was really a great webinar and a great learning discussion. And I know I'm so grateful that everybody took the time off on a Saturday to share their experience in this panel. So please watch out for our next journal club. And we'll continue to do this. Again, I'd like to thank everybody. This was such a fantastic webinar and discussion. It's so much more than either of us could have done alone. Such a great discussion, and I'm sure our audience took away a lot of pearls from this presentation. And again, thank you so much from everybody from Europe and the US for joining us on this Saturday. Any other final comments, Zaf?
No, great, thank you. Special mention to Jane, of course, who's done a lot of hard work with the analysis of the papers. She only got a little bit of time, but I want to commend her deep analysis of the papers. She keeps us in check here in the UK and in Europe with her editorial skills. Thanks to Jane, and thanks to everybody, and I hope to see you all soon.
Yeah, see you all soon. Thank you, everybody. Have a good weekend.
Thank you both. Thanks for sending it on.
Bye. Thank
Take
you.
care. Bye-bye.
Bye, thank you very much.